Microsurgical testicular sperm extraction, that is MTC, should be repeated routinely. And this is published in 2023. And there have been arguments put forth for repetition and against repetition. Let's go through a small summarized statements of these arguments. Now, if you do any conversations after a negative micro TC about this is quite a sad conversation, isn't it? It's about him not being able to have a biological father. Probably he can never become a biological father. And the couples always are interested in taking one more opinion and say, can you repeat a TC? Uh, the second thought process is when you're conveying that a repeat micro TC is necessary, indirectly you're conveying that in spite of doing one micro TC, with a very thorough evaluation of this, you could have missed a sperm. I think it's a very dilemmatous thing. It's okay that a micro TC is done at some other clinic and then you are doing it up yourself at our clinic, but our own result of one micro TC failure of get any sperm, are you going to repeat it or are you going to go straight advice on donor? And this is one nice discussion which has been put forth here. The existing data on a repeat biopsy after one failed micro TC is quite limited. There's one study published by Osman et al., where 125 men with one failed micro TC sperm extraction underwent one more procedure, and the result was about 18.4% of them they could obtain sperm in only these many men. And whenever the histopathological diagnosis was Sertoli cell only syndrome or maturation arrest, the prognosis was pretty bad, that there was no point repeat micro TC for them. But we have to know that this is the only option of biological parenting after one failed micro TC, that you could repeat a micro TC to get that magic sperm. Decision regrets after repeat biopsy is a risk. They will say, well, you attempted one more time. I spent some money. We wasted so much of time. I went through one more surgery, but well, again, it has not been successful and I regret my decision. Most important is the couple's attitude towards acceptance of a donor sperm. I think their knowledge about obtaining their own sperms, also their financial or economic levels, and their intelligence, all these things strategize whether we are going to repeat a micro TC or push them towards a donor sperm acceptance. Many times religious and cultural beliefs are there, that to an extent that if a micro TC fails, they say, well, no more micro TC and we are okay not having a baby now, because our religion and cultural beliefs are not allowing us to go for third party gamete programs. But most important is whenever we have a micro TC and you go to repeat a micro TC, that's a thorough exploration of the testes and intervening into that testes, there is always a risk of hypogonadism. What happens is, as a surgeon or as a reproductive medicine specialist, we don't come across this hypogonadism unless we proactively inquire for it. In our clinic, all the TISA patients are contacted back to report their muscle weaknesses, etc. And we request them after 1 year to do a serum testosterone level, because are they suffering from an iatrogenic hypogonadism? Many times they will go with their muscular weakness and feeling low and lethargy to a general practitioner and will not come to you thinking that this could be a reason, because we probably lack that counseling. We need to counsel them that risk of doing repeated testicular biopsies is iatrogenic hypogonadism. The second part is, suppose you have injured the vasculature. This testis of the non-obstructive azoosperms could be small initially. On top of that, you do this thorough procedure and it could undergo an atrophy. It will be a very small testis, and that's a psychological blow. Because many men, most of the men I would say, having a full scrotal sacs with good sized testis is a very sexual appealing for them. Having an atrophic testis, they feel they have been sexually debilitated. Most important is the histopathological report. It's a routine practice at our places that whenever we do a TC, a part of the sample always goes for histopathological analysis, whether it is a gross TC or a micro TC. This is to find out the histopathological reason there. There could be either hypofunctional testis, there could be maturation arrest, or there could be Sertoli cell only syndrome. In the maturation arrest cases or a Sertoli cell only syndrome, there is no point doing a repeat macro TC. But in a hypofunction, yes, it is still worth doing a repeat macro TC. Now, what is important to note, the surgical technique of doing micro TC is pretty standardized. that you'll be using an operative microscope, you'll be taking this kind of an incision, then under the magnification you will by tube, you'll analyze that, etc., etc. But what about the andrological technique of embryologist? Has been standardized. Like, will it differ from one embryologist to the other? That how much time one spends on the given tubule to identify that magic sperm? And since that is not standardized, we are unable to compare the results of micro TC retrieval from one institute to the other. The surgical technique is okay, but the andrological techniques are not yet standardized. What are the patient factors which determine the decision in repeat TC? If there is a solitary testis, very reluctantly somebody would be willing for one more biopsy, and even as a surgeon you won't be, because if it leads to an testicular atrophy or hypogonadism, then it will be quite a iatrogenic disaster. Age, a younger age we may, but at an older age we won't. Weight loss, have they undergone a sudden weight loss? I'll come to this point. And how much far they are away from a gonadotoxic exposure. For somebody has taken chemotherapy 3 years back and then an immediate macro TC has been negative. Probably after 3 years there could be few sperms there, and doing a macro TC after 2 or 3 years of the gonadotoxic insult could be still worth it. There are certain modifiable factors, and one is obesity. And if you decrease the weight, obesity decreases the clinical pregnancy rate after micro TC, and after a reasonable weight loss, let's say weight loss in double digit, it's worth a try doing a repeat macro TC. Post varicocelectomy in non-obstructive azoospermia, suppose there is a palpable varicocele, and if you repair it, probably again it's worth doing a micro TC, but again a reasonable size of testis should be there. The solitary testis, as I told earlier, doing a repeat macro TC is quite a disheartening thing. But some of the couples will go for some salvage hormonal treatment in the form of clomiphene, letrozole, HCG, HMGs, etc. Though they are not greatly evidence based, and it is not one of the standard of care by all of us. The typical TC, micro TC technique could be that you first do TISA at all the poles and then go in the middle pole and do a micro TC, and that way you are exposing or biopsying on the whole of the testis literally to obtain those magic sperms. Now, will giving some hormonal treatment matter before you do a micro TC for somebody suffering from non-obstructive azoospermia? People have tried the drugs, but there is a limited improvement of 10%. It's not one of the standard of care which we practice. And this is one question which is depicted in this slide, which comes to everybody's mind. A lot of you, in spite of practicing reproductive medicine, may not have an operating microscope. And then you wonder, should we be not doing micro TC? So if you do a TC where you're doing a gross extraction without any magnification of the seminiferous tubules, then you divide the tissue into two parts. One part is sent for histopathological evaluation, and the other part you undergo a screening for teasing it, the tissues and the tubules, to obtain the sperm. Is this technique any different than doing under the microscope and selecting the thicker tube and biopsying it? What has been commonly observed that if we take multiple biopsies at micro TC and put into different tubes, at the end the embryologist puts all the sample into one tube, centrifuges it and discards the supernatant, and the remaining part is analyzed under microscope to find out those magic sperms. So even taking a gross sample could be worth it, but there is no trial vis-a-vis comparing the two techniques of these TC, and that's why we don't have much great information on that. There is an epigenetic test, and this is a study by Brogard published in Journal of Urology 2023, which is on a horizon, and this has been trial and tested in the monkeys, wherein what they did is they looked at some epigenetic parameter, cell-free DNA parameter on the semen, which could tell us whether the testis could have sperms or no sperms. And if something like this comes for humans, that would be a great thing. If you have a testicular volume beyond 12 ml for non-obstructive azoospermia, it is imperative getting the micro TC positive for sperm will be high. And it is really imperative that since 80% of the testicular volume is formed by seminiferous tubules, if you have less seminiferous tubules, the volume will be affected, and volume will directly correlate with the retrieval of the sperms at micro TC. So the summary of this repeating a micro TC could be used in untouched contralateral testis, yes, worth it. After weight reduction, especially a double-digit weight reduction, worth it again. After 2 years, after the chemotherapy exposure has gone by, well worth repeating a micro TC and use of an epigenetic test, which is on the horizon, not yet commonly practiced by all of us. I hope this information helps, and if you have any questions, queries and suggestions or any critical remarks, you're most welcome.